Növbəti Keynote spikerimiz və bugünün yekun son spikeri çox böyük sevinç hissi ilə bildirirəm ki, Doktor Messoud Ashina bizlərləndir. Messoud doktor baş ağrısı və miqren sahəsində beynəlxalq aləmdə tanınmış mütəxəssisdir, ekspertdir. Hazırda Copenhagen Universitetində professor olaraq çalışan Professor Ashina miqrenin nevrobiologiyası və müalicə üsulları ilə bağlı dünya üzrə sözün həqiqi mənasında liderdir. Messoud doktor Dünya Baş Ağrısı Cəmiyyətinin prezidenti olmuş və hal-hazırda Danimarka Baş Ağrı Xəstəlikləri Mərkəzinin direktorudur. O, xüsusilə miqrenin yaranma mexanizmində PACAP və CGRP-nin rolunu dərindən aydınlaşdırmışdır. Bununla da Messoud doktorun araşdırmaları və klinik təcrübəsi miqren xəstələrinin həyat keyfiyyətinin yaxşılaşdırmasında önəmli rol oynayaraq bir çox kliniki innovativ kəşflərə səbəb olubdur. Xüsusilə də Professor Ashina'nın bu yaxınlarda New England Journal of Medicine jurnalında yayımlanan məqaləsi çox böyük səs-küyə səbəb olubdur və bu məqalədə biz PACAP anticissimlərinin infuziyasiyası ilə miqren xəstələrində miqren ataklarının sıxlığının ciddi şəkildə azaldığını görə bilirik. Bu çox sevindirici bir haldır. Belə möhtəşəm elmi tədqiqat və nəticələr İnsan həyat keyfiyyətinin yaxşılaşmasını görmək çox sevindiricidir və eyni zamanda çox ilhamlandırıcıdır. Çox təşəkkür edirik və eyni zamanda sizin çıxışınızı böyük bir maraq və səbirsizliklə gözləyirik.
Çox təşəkkür edirəm. İlk öncə təbrik edirəm cəmiyyətlə. Çox gözəl bir necə deyirlər, layihədir və ilk dəfədir ki, Azərbaycanda Neuroscience elmi konfransı keçirilir və belə bir gənc, zəkalı bir bizim həkimlərimiz, bizim scientistlərimiz, alimlərimiz ki, bura qarışıb. Mən çox sevinirəm buna görə. I'm going to give it in English because I know that you guys were looking forward, for this presentation, and I'm sure that there will be some translation also into Azerbaijani. But also, I think it's important that most of you here in Azerbaijan you start being exposed, to English, because English it is an international language, and in science, English is number one. So my presentation today is about migraine, insights for novel drug discoveries. Just briefly about myself, that I'm graduated from the Azerbaijan Medical School many years ago. I'm not going to say when, it was many years ago. And I did my residency and research in Denmark, in Copenhagen, University of Copenhagen, at the national hospital called Rigshospitalet in Danish language. My passion is about migraine and neuroscience. So I was graduated from the Neuroscience School in Copenhagen University as a PhD and did my research first in tension type headache, and later I moved to migraine. So if I can move forward. Not sure I can move forward. Is it working? I think.
I'll try to help you move from here, but also.
No, I think it's better if it's working here. Is it working?
Yes,
okay, good. So some of my disclosures are here. And I'd like to start with a very interesting question. What makes migraine unique? Why migraine is so important, and why to study migraine? Well, the first thing that will come in your mind when we talk about the migraine, it is just a headache. But I'm going to convince you, it is not just a headache. It's far more complex disorder affecting a lot of people. Now we have, I don't know how many people are sitting here, let's say about 40, 50 people are sitting here, and 10% of you are suffering from migraine. Okay? It's a 1-year prevalence. And if I take females here, 25% experience at least once in a life migraine. If we take population of Azerbaijan Republic, we have about 10 million people, right? 10%, 1 million people will report migraine if you tomorrow do the population-based survey. And at least 200,000 people, they experience migraine attacks at least twice a week. So you can imagine how much burden, how much disability is associated with migraine. This just to illustrate you that migraine is not just a headache. It's a far more complex disease or disorder. And what you see here in this figure, that people with migraine, they're usually asymptomatic between the attacks. They don't have any symptoms. They might have some anxiety, anticipation of attacks are coming, but otherwise, they're asymptomatic. I'm a migrainer myself, by the way. Many people also experience so-called prodrome symptoms. They have a feeling that attacks are on the way. They cannot say exactly what it is. Sometimes they come to physicians, to my clinic, and they say, well, I feel I want to eat something sweet, and I'm sure that the sugar is a trigger of my migraine. It's nothing to do with the sugar. Those are prodromes. Those are symptoms that derives from the deep brain structures, activate the system, and put it like a kickoff for the migraine attack. We have two types of migraine. One is migraine with aura, and another one is migraine without aura. 2/3 of the population, they report attacks without aura. Now, what is aura? Some of you experienced aura attacks. Visual disturbances, usually preceding the headache phase. People are sitting just in the room and suddenly they experience a bit unpleasant visual disturbances in their visual field that are gradually moving over the space and over the time. This is a major difference between aura attacks and stroke, because when stroke strikes, it is like that. You have a visual deficit. But in aura, no, gradual development of the symptoms. 1/3 of the population, they report aura attacks. Now, we come to very important, the hallmark of migraine and the reason why patients are coming to the clinics. Headache, head pain. And what is characteristic for that, it is a recurrent head pain. So it comes and it goes. And it is associated with the nausea, sometimes vomiting, photophobia, and phonophobia. Increased sensitivity for light, increased sensitivity for sound, and the most important one was one word, disability associated with a migraine. When you have a migraine, you stay in the bed. You don't walk around. Or you want to just be still, just sit, because it really hurts. Because just a little physical activity aggravates your pain. And then, the day after, the people report so-called hangover symptoms. The migraine is not over. They have some residual symptoms. We call it postdromal symptoms. Pretty similar to what they experience before attack starts. And then, asymptomatic phase. So this is a migraine attack. And just imagine, if somebody comes to your office and reports 2 days of this attack, okay, every week, it makes 8 days a month. 96 days every year, it's out from your calendar. If you're lucky, if the treatment works, acute treatment, you take painkillers or you take a specific drugs we call triptans for migraine, then you're lucky. But believe me, the patients I see, they are complicated patients. They do not respond to the normal drugs that usually people are happy with. So it's quite interesting disease, but what is important also, a key feature of migraine is that the various triggers can initiate an attack. It's fascinating, The people coming to me and say, Messoud, do something, remove this trigger and cure my migraine. I say, well, I cannot cure your migraine. I can control your migraine. I try to control your migraine, but I cannot cure. Some of the important triggers you see here, menstrual cycle, sleep deprivation, sometimes too much sleep. Weather, even people telling me, when I travel to Spain, I feel better. But I say, listen, even in Spain or in Latin America, people report the same frequency of migraine like in north part of Europe. The same goes for Egypt, by the way. Then there's alcohol. Just a glass of wine can trigger migraine attacks. Okay? And sometimes people say, I do drink because there is such a nice wine, usually it's not a French one. Usually the nice one is an Azerbaijani wine from, from Savalan, probably the best one, never triggers migraine. So, but what they say that, well, sometimes they sacrifice. They have a glass of wine, have a nice glass of wine, but they know that they have in their pocket their medicine so they can take. So my point is that it is a self-limiting. You can treat that. It's a unique feature. And there is also drugs, such as a nitroglycerin. It's all drug used in the cardiology, It's a nitric oxide donor. When you take the drug, you release the nitric oxide, you dilate your coronary arteries, and the way you treat angina, when you have a heart attack or just your coronary arteries are just constricted and you release the nitric oxide. And what is important, you trigger migraine attacks. So the Nobel is famous, right, in Azerbaijan, not only for the oil, but Nobel is also very famous for the dynamite. Because the patent for the dynamite, actually, they introduced the dynamite also in the factories. They used that. So at that time, we're talking about 19th century, the people start observing that the people working with the dynamite start getting bad headaches because of the nitric oxide. So my point is that this is a unique feature and provide us a unique opportunity to study migraine in humans. Now we're talking about neuroscience. In the classical neuroscience, the first things coming in your mind, it's either you do something on rats, mice, or you do it in vitro studies, and then from in vitro, preclinical studies in animals, you move to human studies, right? You call it basic science. Well, now I'm going to convince you that you can do a basic science in humans. And because of this unique feature of migraine, you cannot do it with the Parkinson because you cannot just provoke Parkinson and to study Parkinson, or provoke dementia to study dementia, or provoke epilepsy to study epilepsy. But in case with migraine, you can do that because people accept that. And believe me, even in Azerbaijan, they would accept that if you try to convince them in the polite way, to trigger an attack and to study the basic of basic mechanisms of migraine attack. It's quite unique. So I use this feature to study that, but before I'm going to show you some data, just give you one important point about migraine anatomy and physiology. It is a trigeminal vascular system, the concept of trigeminal vascular system. So there are important structures that I'd like to pay attention. One, it's a perivascular space. Okay, vessels and nerve endings, nociceptors, we heard about nociceptors, surrounding these vessels. Then there is a ganglion. So nociceptive impulses, they travel through the ganglion to the spinal nucleus in the brainstem, from the brainstem to the thalamus, which is a relay station, and then from that to the subcortical and cortical structures, eventually leading to the human experience of what? Migraine pain. So no brain, no pain. But we cannot remove brain, right? So the brain is there to tell us about this unpleasant feeling of a migraine attack. What we know from the preclinical studies, that the different chemicals are released upon activation of the trigeminal vascular system. And those are there. There are some abbreviation, CGRP, calcitonin gene-related peptide, NO, nitric oxide. And then important one that you mentioned, Erhan, it was a PACAP, pituitary adenylate cyclase activating polypeptide. It's a long, name. But this is a point that I'd like to make, that you can study that in humans by provoking attacks. Just imagine that you are one of my migraine patients. You're coming to my office and I say to you, listen, I'd like to study migraine. It's so fascinating. They say, well, do something because I want you to understand my disease that my children are also suffering because there is a strong genetic component in migraine, and also the other patients fellow. We call it how? We call it solidarity. And this is the essence also of the Danish society. that the people are ready to go for the experiments in order us, physicians and neuroscientists, to understand the basic mechanisms of migraine. We can do this kind of triggers that you see the list of them with all these abbreviation of the different molecules, CGRP, PACAP, prostaglandin, nitric oxide, VIP. You can see that usual time of infusion is about 20 minutes. You infuse the drug, or you can take it orally. And then you observe the patient. Either you send the patient home, and you provide a diary, and they fill out the diary, and then they send it back. Or they can stay in the lab and you can do some imaging. You can do functional imaging. You can do structural imaging. You can collect the blood if you're interested in the biomarkers, you know. It's a buzzword. Everybody talks about biomarkers. They will find the biomarkers of disease. So you can collect here in the control situation from attack start to attack end. It's unique. Come on, guys, say it's unique. Huh? Yes, it's unique. Good. So it's unique. You can do that. And you can also do the interventions here, you know. You can give the drug and see whether the drug can prevent the attacks or abort the attacks when the attacks are developed. Now, in the classical pharmacology, when we talk about the classical pharmacology, the drugs that we use usually, they're targeting so-called G-protein coupled receptors. Okay, most of the drugs. Okay, just imagine that this is a cell. We are here in the cell. This is inside the cell. And all these doors are receptors. And the molecules are around this hole in the foyer, and they're trying to bind to this receptor, to these doors, to open the doors and activate a so-called intracellular signaling system. And those different molecules acting on these G-protein coupled receptors. Now, we start by studying G-protein coupled receptors and their importance in the genesis of a migraine attack. Now, you see the cell here, as I explained you before. This is a cell, and we have all these doors receptors. You see the different molecules here. Those are signaling pathways responsible for the genesis of migraine attack. And one of the important family here, it's so-called calcitonin family, okay? And remember 4 letters. CGRP. If you're a neurologist, you're going to use these letters in the next 20 years. Okay? Why? I explain you. Now, in my lab, we studied for many years the role of the CGRP, the calcitonin-generated peptide, in migraine. This molecule is expressed in all these trigeminal vascular system I showed you before. Expressed in the periphery, expressed in the central structures, expressed in the brain. So which one is important? This is a Nobel Prize question, okay? And you're going to address that in the future. If you give the CGRP to people with migraine, more than 70% of them will report migraine attacks. So just imagine that you are a migraine patient, you're coming to me, and I give you CGRP, and I give you a placebo. And you come in the random order, and you don't know which day what you receive. And then if you do the group analysis, more than 70% of people will report attacks. Okay? This suggests that this molecule is important for the genesis of a migraine attack. And this suggests that if you block this molecule or these doors, receptors, you might have a drug. Huh? Follow me? Yes. Now, but in this family, with this family of these CGRP peptides, it's not alone. We have some siblings here. We have some brothers and sisters, adrenomedulin and amylin. And look at these receptors. They share these G-protein coupled receptors, and some of them acting not only on their own receptors, but also cross the other receptors. Since we know now that the CGRP is important because it triggers attacks, and now we have drugs, monoclonal antibodies, that we use against CGRP or its receptors, and they're registered, they're licensed, and in fact that I know people in Azerbaijan, they're taking this medication, monoclonal antibodies. It's a monthly administration, injection, because monoclonal antibodies, they have a long half-life, so they act over 1 month. So 1 month regimen every month, and you prevent half of your migraine attacks. Fascinating. Now, the question is, is it CGRP alone or maybe other molecules involved as well? Adrenomedulin and amylin. And if you are in Ashina's lab, what are you going to do? You're going to give them, right? You're going to give the adrenomedulin, you're going to give amylin to see whether you can trigger migraine attacks. And what happened is that, as I showed you before, more than 70% develop attacks after the CGRP. And look what happens here. When we give the adrenomedulin, more than 55% of people, they also report migraine attacks. And then I gave the pramlintide, which is an amylin agonist, 41%, less hypersensitive. You might ask, maybe it's not so important, but maybe the dose is not the right dose. Maybe I need a longer duration, longer exposure, and then I might get to the same level, more than 70%. But this is a different point. The major point is that those molecules are involved in the genesis of migraine attack. Now I explained to you we have monoclonal antibodies and small antagonists against the receptor, G protein coupled receptors. In our practice, we use them now to treat migraine attacks. GPANs, it's a class of medications. They work acutely and they work for prevention, prophylactics, so everyday tablets. Monoclonal antibodies, as I explained before, they are parentally administered. So they are using as a subcut injections or IV. There is a one drug which is an IV drug. Now, my studies suggested that those are also a possible candidates. Amylin receptor or amylin itself, adrenomedulin receptor or adrenomedulin itself. In fact, there is a monoclonal antibody against adrenomedulin using for treat of sepsis. So we are now planning to study this monoclonal antibody to see whether we can block adrenomedulin effect in humans. And maybe we can suggest that as a new drug. Now next move to the most exciting part. I told you about 4 letters the next 20 years. In the next 5 years, and maybe if we're lucky, if we confirm in the next 20 years, we're going to hear about 5 letters. Pituitary adenylate cyclase activating polypeptide, PACAP. Now you say, well, it is something with the pituitary gland. Well, most of the peptides, when you first time discover them, you usually name that according to anatomy where you describe them, you found them. Like, the vasoactive intestinal peptide. You say, well, intestinal and migraine, what has it to do with the migraine? No, because it was discovered there. But those peptides are expressed throughout this trigeminal vascular system that I showed you before. Now, in human body, we have 2 isoforms of PACAP. PACAP 38, PACAP 27. The only difference is the number of amino acids. That's it. They are strong vasodilators, by the way, like CGRP. They are strong vasodilators as a nitric oxide. And they also have a brother and sister, whatever you call it, called vasoactive intestinal peptide. Why? Because they're related, and I'm going to show you that they share receptors. It's interesting. Now, many years ago, 2009, that was the first study. One of my PhD students conducted this study, which was a double-blind study, was a placebo-controlled study, when we gave the PACAP infusion to people with migraine, and look what happened. 58% of them, they developed migraine attacks after infusion of PACAP 38. 10 years later, another my PhD student, I asked him to give another isoform, PACAP 27, which is in a less concentration in human body compared to the PACAP 38. And what happened? More than 50% of people again reported migraine attacks. But after 2009, I wrote a paper, a hypothesis paper, where I suggested that the PACAP or its receptors could be a drug target for future treatment of migraine. And then there was one company approached me and told me, Messoud, we're going to work with you because we have monoclonal antibody against that. I was so excited because I wanted to prove the hypothesis. Whether it's right or wrong, it doesn't matter. This is important. For the scientist, you know that. It's crucial. You have to test everything what you suggest. What happens is that we looked at the receptors. As I told you before, PACAP and VIP, they shared receptors. And you can see it here, VPAC1, VPAC2, and PAC1. Now, they're G protein coupled receptors. Remember these doors? Good. And what happens is that we tested first this one, monoclonal antibody against PAC1 receptor. That was an American company approached me and said, Messoud, we have a monoclonal antibody against this receptor based on your hypothesis. And now you ask me why my hypothesis was wrong. Because when we gave PACAP and VIP, in spite of the similarities, we had a lot of people reporting migraine attacks after the PACAP 38, but very few after VIP. And now I said, well, maybe because VIP has less affinity to the PAC1 receptor, and that's why the PAC1 receptor probably is a key for this effect of PACAP. But it proved to be wrong. But pharmacologists told me, listen, Messoud, maybe those are just different splice variance receptors that you are, trying to block. Maybe it's not potent enough. So we don't know. But bottom line is, the study failed. This monoclonal antibody failed. The next question is, can we block the PACAP itself? So in human body, when we talk about monoclonal antibodies, there is two ways you can treat people with monoclonal antibody. One, you block the receptor, you block the doors. Another way, you go out in the foyer and you block the ligand, free circulating ligand. So here we suggest that maybe the free circulating ligand is a key. So I put the question mark for the two compounds. And one of the Danish companies, Lundbeck, they owe one of these compounds. They approached me and asked me to address this question. In fact, I convinced them that this is the right way to move forward. I said, well, let's do the study, proof of mechanism. Not proof of concept study, but proof of mechanism. If I give the PACAP to any of you, and you are not suffering from migraine, you will get flushing, heart rate will increase, the blood pressure a little bit drop, you will feel some puffing in the face because it's a quite powerful vasodilator. And I told them, don't do it in migraine. Just do it in healthy people and see whether you can block physiological response in humans in vivo, in vivo. Not in mice, not in rats, not in guinea pigs, in humans. And what we did is that was our hypothesis, that the pre-treatment with this monoclonal antibody will bind to the PACAP and will prevent PACAP-induced head pain, just a head pain, not migraine, in people without migraine, and all these side effects of PACAP. And what you see here, it's really interesting. When you give the PACAP, you see the long-lasting dilation of the superficial temporal artery. Look at this, 120 minutes, it doesn't go to the baseline. It's still there, this dilation. But if you pre-treat with this drug, you have flat line here. You block this vasodilation. And you also, in fact, prevent the headache. You can see the difference. So when we have this proof of mechanism, I said, guys, we're ready now for proof of concept. Let's move to the proof of concept. It's a small study, but it's important. If we prove the concept is right, then we move to the next level. It's a phase 3 study with a monoclonal antibody against PACAP. So this is a proof of concept study we just recently published, what Elhan mentioned, in New England Journal of Medicine. 2-arm study, you see the 2 doses. But what we see, the primary endpoint was the difference between the high dose, 750 milligram, compared to placebo. You see the eligible participants, patients with migraine, high frequency and also chronic migraine, and they had a documented failure with a 2 to 4 medications before, prophylactic medication. So they were in fact some kind of refractory patients, you can call them. It was a risky study, to study proof of concept in people who are really failed with the 2 to 4 medications. Well, these are the results that we published. You can see how many participants. Again, I just want to underscore, it is a small number of people we're talking about because it's a proof of concept study. So the next step is to move to the phase 3. But you can see the difference. Well, you can say, well, it's a very small difference. But the fact is that when you have a cumulative difference here, those graphs also include those with no response. That was a little bit misleading when you see such small difference. But the bottom line is significant, it worked, and there is a chance that it can also work in phase 3. If it works in phase 3, then we have a new drug. New monoclonal antibody against the PACAP. Now, since I told you about these 4 letters, the CGRP, you might say, is it any connection between this CGRP and PACAP? Any way to see whether there is a different signaling pathways? Why it's so important? So just imagine that, Elhan is suffering from migraine and you're coming to me and I give you CGRP, monoclonal antibody. In 3 months you come back and say, Messoud, no effect. I say, maybe we give you anti-PACAP and you respond for the anti-PACAP. Meaning that your migraine can be different from his migraine or my migraine. It's a nice thought, we don't know, and that's why to test that, whether it is a different signaling pathways, we conducted this study by addressing this question. Is PACAP38 signaling independent of CGRP? And how can we do it? Can PACAP38 and its receptor be therapeutic targets for migraine, including non-responsive individuals to CGRP pathways? Like we talk about that now. Now, you block the CGRP with a monoclonal antibody. We have the drug, and it works. Now, then, when we pre-treat them, we give them PACAP. The idea is that it should block the PACAP-induced migraine or fail to block the migraine. And what we showed that when you give the eptinezumab, which is a monoclonal antibody against CGRP, you can see the response rate for the PACAP and the placebo, no difference. So no difference. So PACAP38 induced migraine attack despite of neutralizing the CGRP molecule. So it's independent. So it's a different. Well, is it really in the real life also we are different in terms of our signaling pathway? The future will show. I'm not sure about that. But the bottom line is here, you see no effect. Okay. Now we're coming, do I have time? Yeah. Now we're coming to the most exciting part of my talk. If it's proven in the future true, this one, then we have a big, big discovery. And believe me, it's going to be a big one. Remember that. So we are downstream molecules here. So just pay attention. Again, we are in the cell. This is a cell. You see the different receptors here. But what's interesting is that PACAP is acting on the G protein coupled receptor here. The CGRP is also acting here. Nitric oxide is different. Nitric oxide doesn't respect anything. It just goes inside the cell because it is a gaseous molecule, right? It doesn't require a receptor. It goes there. And then it goes there and activates so-called cyclic GMP signaling pathway. Why it's important? Because these discoveries led to the Nobel Prize. Nitric oxide and the cyclic GMP. And if you give the drug, which prevents the downbreaking of the cyclic GMP and accumulating, and you probably heard about this famous drug, Viagra. So if you take the Viagra and give it to the female population with migraine, 80% of them will develop migraine attacks. So you are hypersensitive for that, for cyclic GMP signaling pathway. Now, when we talk about the CGRP and PACAP, they're acting on the parallel on the cyclic AMP signaling pathway. And if you give the drug which prevents the downregulation of the cyclic AMP, the drug called silastazol, I don't know if you have it in Azerbaijan, silastazol, in many countries it is used for the treatment of claudication intermittens. When you have your, we have it here, right? So if you give this medication, silastazol, you prevent the downbreaking of cyclic AMP, you accumulate cyclic AMP inside the cell, and you get a migraine attack in 80% of people. You see it here. And then we ask the question. This is probably the final one. The ATP potassium channel or the large conductance calcium activated potassium channels. Those channels are very important because those channels, in fact, are dilating the vessels. When you open these channels, you dilate the vessel. You hyperpolarize the vessel, the smooth muscle cell, and then you dilate the vessel. Now, these channels are expressed in all migraine-related structures. I showed you before, the trigeminal vascular system. Those channels are also activated by several key molecules that I told you are important in migraine pathogenesis, like nitric oxide, CGRP, PACAP. And the most important is, back in the 90s, those channel openers were studied in humans to treat what? Hypertension. And guess what? Did it work? Yes, it worked very well. But what happened with the program? They stopped the program. Why they stopped the program? Because of side effect. What kind of side effect? What kind of side effect? Just imagine. Headache. Because of headache, they stopped the program. I say, wow, it's interesting. And I told to one of my PhD students, I said, let's study that in migraine. Let's see whether we can provoke migraine using these agents. And what happened was fascinating. Almost all migraine people, they had a full-blown migraine attacks. Very bad migraine attacks. And the localization of those attacks, sorry, we'll go back. Localization of those attacks, you can see it pretty similar to their spontaneous attacks. This is placebo response. Actually, it's not a placebo. We call it nocebo response. When you get something like a saline, but you feel that you have a headache. Then we did it with a big channel opener. You can see more than 90% of people also develop migraine attacks here. So my point is that from the G protein coupled receptors, we're inducing migraine attacks. We're going inside the cell, we're inducing migraine attacks, and we're going more deeper by opening those channels, and we're inducing the migraine attacks. Now, this is hypothesis that I suggested 4 years ago in my review paper in New England. You can find that in the supplemental files. This is what you see here. It's a genesis of migraine attack. You're acting on the G protein coupled receptor here. You hypolarize the cell, you dilate the cell, or you just go directly by opening these channels and you dilate the vessel. Is it new? No. Everybody knows that this is a basic physiology. So you activate these channels, you open these channels, and you dilate the vessel. But now comes something very important. And my answer is that this is just hypothesis, and I don't know if it's going to be true or wrong. How to explain this vascular signaling translates into the sensory signaling that we heard before results in the unpleasant feeling of pain. So this coupling, it's a key. And I suggested that the release of the potassium in the extracellular space will go there and activate sensitized nociceptors. So what Dr. Zulfigar showed you, the basic mechanisms of pain. So one of the basic mechanisms of pain, release of the different mediators and activation and sensitization of the nociceptors. This is classical pain physiology. So here I'm trying to explain how the vascular signaling can translate into this bad head pain and eventually results in this box 4, activation of the brain structures that results in your experience of head pain and migraine attacks. So this is something that I'd like you guys from the preclinical group, to address this question if you're interested, of course, in migraine, because this is something I cannot understand I cannot study in humans in vivo, and that's why I established also preclinical lab now in my lab. So we're going to do a reverse translation. So we ask the questions in humans, and then we move to animals. Not traditional way, from animals to humans. Okay? Reverse translational. Okay? This is what we do. Now, the conclusions are the following. Opening of these channels are very important. So the downstream mechanisms are very important. And what we know that they cause attacks without aura. And we know that their strongest provocation migraine ever studied. We showed that. This is data. And we suggest that blocking of these channels as a new therapeutic target downstream from the signaling molecules that I showed you before. Okay, downstream. Maybe we can increase efficacy by acting in the downstream mechanism. This is a just hypothesis right now. But you're all very smart people here. You can tell me, Messoud, listen, those channels are everywhere in human body. Don't mess with these channels. This is the reason that pharmacology mostly using not the channel blockers. They use a G protein coupled receptor blockers. So they avoid going into the channels. Well, you are right. It is present in pancreas, in brain. It's present in cardiac and skeletal muscles. Well, if you start opening those channels, you can create some problem, or blocking these channels, even worse. But listen, when we opened those channels, we didn't see any problems. But it was transient. Okay, we didn't see any problems. But blocking could be a problem. That's why we suggested that there is a one way to do it is to block this specific subunit, because the channels are quite complex. That's why we're trying, convince the companies to go and target so-called SUR2B subunit KIR61, because they are located in the extracerebral and cerebral vessels. So moving to this particular compartment to avoid heart, to avoid brain per se, we might see some drugs efficacious and safe in the future. My key points today, okay? All signaling molecules involved in the genesis of migraine attacks are vasodilators. But remember, I'm not claiming that the migraine is just a dilation of the vessels. No, they're just triggers, okay? Now, modulation of the nociceptive transmission by ion channels, main potassium channels, I showed you now, maybe a final, maybe you don't like the word final, maybe a common, let's say, pathway in the genesis of migraine attack. And the insights from the human models that I showed you, this reverse translational, provided us a very important information about the pathogenesis of migraine attack and also opened the avenue of the drugs. And what we see also that not all of them are provided true. Okay, it's not like everything is so nice. It just illustrates how complex this disease is, and how fascinating it is, specifically in neuroscience. We had so tremendous development in the last 30 years. It's amazing. We have new class of medications, guys. We talk about the pain field, that over the last 30 years, nothing really happened in the pain field, unfortunately. We use the same drugs. Amitriptyline, nortriptyline, gabapentin, pregabalin, the same. Nothing. But in migraine, triptans, gepants, monoclonal antibodies, and maybe in the future PACAP, and maybe targeting the downstream mechanisms also. So I'd like just to thank the funding of all this, Limbic Foundation, Novo Nordisk Foundation. The most important one is the participants with migraine and also healthy volunteers, and all my group of colleagues that they did these studies, not me. Okay, I was the lead of the lab, but they did. Without these guys, never this data you will see today. Thank you very much for your attention.
Thank you for the presentation. I truly hope no one has a question, because I think I have 4 or 5. I will let Dominic, but I guess I'll ask the audience. Unfortunately, there are questions. So
First of all, it was a great presentation, very interesting. I read before about new studies going on the use of botulinum toxin for the treatment of migraine. I wanted to know, if you used it before, and what are the main differences, and if maybe this medicine could be used for since there is different types of migraines, maybe for one type of migraine and the botulinum toxin for other, or if there is other difference between.
Okay, so migraine therapy includes also the treatment with onabotulinum toxin type A. And guess how it was discovered? Do you know how it was discovered? Where people use the, Botox. Yeah, cosmetics, right? Yeah. And which country you would suggest, not Colombia, which country you would suggest if you move a little bit north? Not Brazil, more north. US, yeah. In which part of US you will expect that? California, bravo. So in California, in fact, that you know, they start coming, you know, all these celebrities, they start coming back to their neurologists and say, well, something miracle happened, you know, that I start getting my Botox for my cosmetic reasons, and I had less migraine. And guess what? The company, of course, jumped on that because they say, well, it's a lot of money, right? We can earn a lot of money. We can see whether it works or not works. And they conducted the studies, a so-called double-blind studies with a placebo-controlled, the sham procedure, including in patients with chronic migraine. And that's why this drug was approved for this particular group of patients called chronic migraine. What is chronic migraine? You must have at least 15 days of migraine per month, at least, or headache days. And 8 out of these 15 days is arbitrary migraine. Then you're eligible for Botox. Okay? So Botox works by reducing the frequency of migraine days, intensity, but also duration of the attacks. And the question is, how? The same question also goes, how the beta blocker works in migraine. You know, it's the most widely used. Or candesartan, which is also used for the migraine, how they work. We don't know. Those are non-targeted therapies, which were discovered just by an accident and then conducted double-blind studies and showed that now they work. We have some speculation about the Botox. Maybe it is blocking because you do the 31 injection sites, you know, in the pericranial region and the shoulder here, 31 sites. This is called PREMPT protocol. And according to this protocol, you should use this protocol, you know, to achieve the efficacy in migraine. Every 3 months cycles, you give that. 2 cycles fail, then you are not responder. Okay, you're out. If not, you can continue. Now, the speculation goes for, you probably have release of these different chemicals, including the CGRP and other chemicals, from the nerve endings in the subcutaneous, but also muscle tissue. And by blocking this effect in cumulative way, you're blocking one part of the, let's say, input coming, nociceptive input coming during the migraine attacks. And because you modulate something in the periphery, you can affect central structures as well. This is a pure speculation. Nobody exactly knows how it works. But my experience is that it doesn't work in everyone, but it works. You know, it works in some people and they're happy. So because they keep coming. Very interesting about migraine people is that if something not working, they're not going to take it. They just stop taking that. Okay? So it works. And it is evidence-based in chronic migraine.
So I guess we have more questions.
No. Thank you, doctor, for the presentation. So I wanted to, I just was curious when you mentioned about the monoclonal antibodies. And I just wanted to be clear if like the monoclonal antibodies are for blocking specifically the CGRP receptors or the CGRP itself. And if it's one of them, why not trying the other or both at the same time? I don't know.
Oh, yeah, it's a very good question. You know, we have 4 monoclonal antibodies against CGRP pathway. One of them, it's a monoclonal antibody against CGRP receptor called erenobab. And 3 of them are anti-ligand, so they block the CGRP itself. If you look, there is no head-to-head trials, but if you look at the trials compared to placebo, they're pretty similar. There's no such difference between these different monoclonal antibodies. These 3 of them are subcutaneous, and one of them anti-ligand, one of the 3 anti-ligands is IV. Okay? There is no difference. Now you say, is it any differences between those in the clinical practice? Well, it's a good question. The reason for that is that for many years we used triptans, you know, the acute drugs. We have 7 triptans, but it's amazing that how different are people in response to triptans. One triptan works for you, but not working for me. So that's why I'm liberal in this context. I want to try the different monoclonal antibodies. And the most logical way would be if I have somebody taking monoclonal antibody against receptor, I will switch to the anti-ligand or vice versa. You understand what I mean? So combining this is a cowboy method, you know. And then you are not cowboy. You are from Honduras, right? I mean, yeah. So I'm sure that Americans, they will probably try that because they do these kind of things there. But in Europe, we're very conservative. We are monotherapists, and that's why the combination of that. And also, I would concern about the safety of blocking both receptor and anti-ligand. No, I would not do that.
Thank you.
Okay, I guess I can be selfish and ask some questions myself. So more on the speculation line, I guess these receptors or the ligands that are leading to cause migraine also exist in the normal people. So what is then the difference? Why in patients it causes migraine while the others it doesn't?
Yeah, but this is a Nobel Prize question. So just imagine all these people are sitting here. They are not migraine sufferers. They don't have any history of migraine, no first-degree relatives with migraine, nothing. They are healthy people. I invite all of you now to my lab, and I give you these triggers. All of you will develop some side effects of this drug, like Viagra, flushing, or something like that. But you will also develop a bit head pain. A bit head pain. But it will be very transient, maximum 1 hour, and it will go away. So evolutionary, we all are sensitive for the vasodilators, all of us, vasodilators, and we express this oversensitivity or the hypersensitivity in head pain, not in low back pain, not pain in your joint, not pain here in the shoulder, just in the head. So your receptors, your vessels are completely different from the vessels here because you also dilate here, but you don't get pain here. So evolutionary, we all are predisposed for this. But why, if I take the same amount of people here and all of them are suffering from migraine, why they develop the migraine attacks? This is a key question. Why this head pain transforms gradually into the full-blown migraine attack? This is what I tried to explain in my hypothesis paper with a downstream mechanism. And you can say, why people with migraine react? Well, then you're going to kill my research, you know, because it is a very complex question. But it is not just a head pain they develop. They develop full-blown migraine attacks. And this is a difference between this group of people with migraine and this group of people not suffering from migraine. They don't develop migraine attacks. But maybe, now I'm going to be very provocative. Maybe all of them are, yes, not migraineurs. But if I start giving them too much of these triggers, too long of these triggers, maybe some of them, they start developing migraine attacks. Maybe migraine, it is like evolutionary like a seizure. Huh, Olivia? Maybe it's just a seizure. Can you induce seizure in everybody here? Yes. If you do the, electroconvulsive therapy, to all the people, but we will probably have a different threshold, right? Maybe somebody requires a huge stimulation before you trigger the epileptic seizure. And maybe the same with the migraine. So we don't know. We don't know. Those are very important questions. But right now we can say that this population reacts completely different way from the population with migraine.
I'll try to contain my instincts and ask only one more question, please. About your, again, hypothesis for the potassium presence in the brain could be the culprit. Do we have any evidence whatsoever that if you just inject potassium, so if you mimic the increase of potassium in the extracellular fluid in the brain?
Extracellular space, yeah, but,
okay.
yeah, but, yeah. I guess your question is probably why vessel, why not neurons?
Or my question is more in the direction that you can mimic this blood-delivered potassium in the brain by just targeting, like injecting, for example.
You're a physiologist, right?
I am a fundamental researcher.
Fundamental researcher. What happens if you have in the neuronal cells, you have increased potassium in the extracellular space?
Yeah,
you will get a completely different reaction. You will get anti-nociceptive effect.
Because of the hypergrowth.
Absolutely. This is a basic, right? And that's why, I tested your hypothesis. You know what I did? I asked one of my PhD students to inject this drug, levochromocaline, into your muscle here and into your skin also here. And guess what? No pain. You see? So it's not direct effect on the neurons. So it goes via the smooth muscle cells, the vessels. And that's why I tried to explain that, by increase of this in extracellular space. And then synthesizing the nociceptors and triggering the chain of pain. So that's why it's not on neurons. It's not there. We are opening these channels and inducing attacks.
Well, I guess that's from my side for now. And if you have no more, please. Okay, sorry, I got interrupted. One more.
Thank you very much. So, as a neurosurgeon, I'm not very much interested in migraines, but we deal with this much more formidable disease. Maybe you've heard about that, cerebral vasospasm following subarachnoid hemorrhage.
Yes.
And do you have any updates on that point? Have you used any of these potential molecules or pathways to treat or candidates to treat vasospasm, because that's what really cripples people, after the aneurysmal rupture, and I've lost patients to that.
Excellent question. Excellent question, and it's natural. It's coming from neurosurgeon, because we are neurologists. We all know, and we are really afraid of the condition called subarachnoidal hemorrhage, right? And it could be different etiology for that. It could be spontaneous due to the aneurysms. It could be traumatic subarachnoidal hemorrhages. But while we can control that in the beginning, one of the complications of this condition is a vasospasm. And it usually comes later, in the course of this devastating condition, SAH, subarachnoidal hemorrhage. Why it's a fascinating question? I'll explain why. Because many years ago, back in the 80s, back in the 70s, when we looked at the vessel, we knew about the vessel only with the two transmitters, acetylcholine and also noradrenaline. That's it. But with the introduction of the radioimmunoassay, we start mapping the different molecules. And one of the molecules discovered at that time was CGRP. And what is CGRP? 4 letters, calcitonin gene-related peptide. Discovered again, sorry guys, in California, in La Jolla, with the Rosenfield group, Michael Rosenfield group. And when they discovered this, they didn't know about that, but later they showed it's a very strong vasodilator. Wow. And one Swedish scientist who won the Brain Prize, which is corresponding to the Nobel Prize in Neuroscience, it's actually given in Denmark. By the way, guys, if you want to win the Brain Prize, you have to come to Denmark. And this guy, he studied this molecule in the vessels, in the human cerebral vessels, to show for the first time expression of this peptide there, and also dilating effect and involving intrageminal autonomic reflex. And he suggested using the CGRP per se to treat vasospasm during the subarachnoidal hemorrhage. No, actually, they stopped this program. There was a PhD dissertation from the Norwegian guy, this Swedish guy was a supervisor of this Norwegian scientist. And I read this thesis many years ago, back in the 90s, because I was interested in context of migraine. But I read about that the discovery of the CGRP actually started for the regulation of the cerebral blood flow. And in this context of using the CGRP, not the blockers, using that to treat the subarachnoidal hemorrhage. And now, when we have these monoclonal antibodies, some of my friends, neurosurgeons, are calling me and say, Messoud, we have some guys, with aneurysms, etc., bad migraines. Do you want to use that? I say, no, don't use that, because they are, in fact, blockers. I don't know if they develop the subarachnoidal hemorrhage, and if you have this long-lasting drug in your body, how your vasospasm will evolve. And that's why I say, no way, not for this. I'm too careful with that, and I say no. But it is a fascinating topic, and I'm sure that those molecules that I showed, that the vasodilators, one way around, they involved in the vasospasm, and maybe in the future we will see something. But then you need to use them per se, not the antibodies, not the antagonists. But the CGRP was a very interesting question. Was actually suggested at that time using the CGRP as infusion for that. But I think it will give you a bad headache, by the way. Yeah. Interesting.
All right, I guess this time you're done.
Thank you.
So
Thank
much.
you.
Thank you.